Hello, I'm CherylHolmes, and I'm here to talk to you today about my favorite subject, which is recognition and assessment of the critically ill patient. So here are the learning objectives. Today, in the context of a case that I had in my own critical care practice, we are going to use this case to recognize the early signs and symptoms of critical illness, apply a framework for the assessment and stabilization of the critically ill patient, and specify how treatments and assessments should be delivered and interventions should be delivered in relation to assessment. Critical illness is often recognized in the late stages, and in fact, the common final pathway for any critical illness is cardiopulmonary arrest. Sudden deterioration is often preceded, however, by signs and symptoms which can be detected earlier on. So the goal of our presentation and our discussion today is to allow you early identification of patients who are at risk of deteriorating, identify their main physiologic problem, determine its underlying cause, and begin specific treatments. So the longer the interval between the onset of an acute illness and the appropriate interventions, the more likely a patient's condition will deteriorate to cardiopulmonary arrest. So let's evaluate a case that might be encountered in your emergency department or hospital practice. So this was a patient that I had that I was asked to see. He is Derek Hamilton. He was a 54-year-old architect who was day 6 post-urgent hemicolectomy, who was acutely short of breath. And the consult that I got over the phone was that he was complaining of abdominal and chest pain. His respiratory rate was 26 beats per minute. Heart rate was 118 beats per minute. Blood pressure was 100/72, and his oxygen saturation was 90% on room air. Significantly, he was febrile at 38.5 degrees. So, is this patient seriously ill? That's the first question. And then the second question would be, what lab and x-ray investigations would be appropriate to order for this patient? So many of you work in hospitals and clinics where there is a critical care outreach team. And this is an example of a poster on a ward that tells the healthcare staff when they need to call for help. And so it's based on the ABCD, which is airway, breathing, circulation, and disability. And it gives nursing staff and other healthcare workers guidance as to when they need to call for help. So how sick is this patient? Well, so far based on these criteria, you might be concerned, but you're probably not yet calling for a transfer to a higher level of care, but you want to definitely assess the patient and apply this urgent assessment framework that we're going to give you. So assessment of critical illness begins with finding out what is their recent medical or surgical history. Go where the surgeon went was the advice that I was given. What comorbid conditions do they have? What are their current vital signs? And what is the vital sign trend, which is probably even more important? So what information could I help you identify risk factors for serious illness? First, temporally, helpful information can be broken down into 3 categories. First is the patient's background health, which could suggest potential complications that might be anticipated. So in his case, recent surgery. Second is the current disease process. In this case, it appears to be an infection based on his temperature, his abdominal and chest pain. And third is the severity of his immediate physiologic derangement. So what are his vital signs telling you, and what is the trend telling you? Is it necessary to know the diagnosis at this point? Absolutely not. We're working through the criteria to delineate the severity of the illness, and we should provide immediately therapeutic interventions such as the needs are identified. The patient will be stabilized before the diagnostic evaluation is complete. And I would also like to add that jumping to an early diagnosis at this stage will open you up for numerous cognitive biases, many of which are, you've probably heard about, but like confirmation bias. So I've seen a trap where people jump to a diagnosis like, pulmonary embolism too early on, and they ignore other data that might be important, such as the fever. So how sick is this patient? That question needs to be answered quickly. The temporal approach to this is first broken down into primary and secondary survey. The primary survey seeks to identify immediate life-threatening problems, such as an airway obstruction, during the first few minutes of contact. We identify the primary physiologic insult before we even embark on going down the road of coming to a diagnosis. The secondary survey helps you to understand the underlying cause and directs subsequent evaluation and review. So you've arrived to the ward to evaluate Derek, who may be seriously ill. What information would be most helpful? You've probably, hopefully, received a brief history before making it to the bedside. The initial examination must be brief, directed, and concentrated on the basic elements of airway, breathing, circulation, and consciousness. Early interventions should proceed immediately after identifying problems in those areas. Then, a review of the patient's past and more recent medical history from the medical record, as well as current complaints and physical examination findings, are essential. Now, I want to stop here and say another trap is to not see the patient and go and examine the chart. So, do not do this. Don't be that person. Go and see the patient. Establish the ABCD. And if you have somebody with you, ask them to go and examine the chart and review the chart to give you an update on all of the relevant information. So, critically ill patients have abnormal physiology that must be measured and tracked, which you can do from the chart. The values and trends of this data provides key information about the patient's status and can guide treatment. Additional investigative tests should be based on the findings of their physical and of their history and physical exam, as well as previous test results. So the patient's history contributes the most to the diagnosis. In the primary survey, a relevant history includes the current main complaints, identifying why you have been called to the bedside. You typically have this information from the initial phone call, text, or page, and it can be relayed by witnesses, such as the patient's circle of support that may be available in the room. Also medical staff or relatives as you arrive. The primary survey can also include any recent surgeries, in this patient's case, traumas, or medications that have been started or discontinued. So back to our patient. The information obtained in the initial survey has a focused view of the patient's major symptoms and coexisting illnesses such as fever and shortness of breath. Details related to the visit or admission would be helpful. Did they have a surgical procedure? Is there any hemorrhage or potential infectious complication present? What medications did the patient receive? Was DVT prophylaxis given? What was a long-term medication held? Remember that the most common cause of the immediate physiologic derangement is related to the most invasive procedure. So here's the information that you get. He was admitted with an obstructing adenocarcinoma. He was taken to the OR where a primary resection and anastomosis was performed. His post-op course was characterized by slowness to mobilize. He complained of abdominal and chest pain. There was no NG tube, and he vomited last night. He called the nurse this morning. She found him to be disoriented and restless and complaining of the urge to have a bowel movement. An important, very important piece of information was he states that he can't breathe. When a patient tells you this, or they have a symptom of impending doom, such as, I feel like I'm going to die, doctor, take this very, very seriously. Additional helpful information that your partner gleaned from the chart. There wasn't much. He does have a history of hypertension. He normally takes Ramipril. His normal blood pressure, kind of is in the 140s to 160s. So that tells you that his recent blood pressure is probably not normal for him. And importantly, he is allergic to penicillin because you suspect an infection might be present. And so you're going to likely going to start antibiotics, and you need to remember that he is allergic to penicillin. So the immediate concerns are recalled by the ABC, and I would add DEF, mnemonic. So think of threats to the airway, breathing, circulation, and disability or level of consciousness. I'm going to also add E for examine and head to toe, and F is for friends. And I'm going to give you a gift today, which is the SBAR Urgent Communication Tool. So the evaluation of these concerns begins by taking a look, listen, and feel approach. Consider the many signs, stated and unstated, obvious and subtle, that might suggest progressive respiratory failure. So let's start with A and B. Compromised oxygen transport, beginning with a deterioration of respiratory function, is a very important pathway of critical illness. For the A, airway, observe the mouth and chest. Listen for bad sounds. Bad sounds is my thing. So here's a few that I'm going to give you, which is stridor, which is airway obstruction, and which is also probably airway blocked airway. Second, document the respiratory rate and pattern. Tachypnea is the first indicator of critical illness. I cannot stress this to you enough. If you remember nothing else from this talk, I want you to remember to always observe and listen and document the respiratory rate. This is the vital sign that is the most important, and it's the most often overlooked. So if you go to any chart and you look for a respiratory rate, typically you will see the number 16, and you'll see it perpetuated in the chart, or 20. And that tells you that people haven't stopped and listened and documented it. Why? Because it's not measured by a machine. So an automated machine can give you the heart rate, the blood pressure, the pulse oximetry, the temperature, but it doesn't give you the respiratory rate. So people don't measure it and document it. And yet, it is the single most important vital sign in detecting impending respiratory failure. So remember to count and document the respiratory rate. Look at the patient for work of breathing, use of accessory muscles, paradoxical breathing, grunting respirations, and check the oxyhemoglobin status with a finger probe. Changes in blood pressure are relatively late finding and very insensitive signs of inadequate circulation. So a patient's blood pressure will be, central blood pressure will be defended at the expense of the peripheral circulation. And so you have to look for other signs of decreased perfusion, such as mental status changes, urine output, and skin temperature. So cool and mottled or hyperemic and mottled are evidence of circulatory derangement. Mental status changes, can't emphasize that enough. So when I look back in the chart on patients who have come to the ICU with cardiopulmonary arrest from the hospital ward, when I look back in the chart, the first sign of a patient's deterioration is patient confused. Patient confused, restless, pulling at lines and tubes. That's the first thing. Before there's a change in the vital signs, before there's a change in the urine output or the white count. And so that's a very important sign. And then look at the central and peripheral pulses. So disability or level of consciousness. A very helpful mnemonic is AVPU. People have trouble remembering Glasgow Coma Scale, which has really only been validated in the trauma population. So AVPU is very easy to remember. Is the patient alert? Did they respond only to verbal stimuli? Did they respond only to painful stimuli? Or are they unresponsive? And so responding only to painful stimuli, unresponsive, is a sign that they are not protecting their airway. Then pupillary exam. Why do we want to examine the pupils? Pinpoint pupils could be a sign of an opiate overdose. Unequal pupils could be a sign that there's something structural going on in the brain. Fixed dilated pupils, very serious. And then under disability and consciousness, I put blood glucose as well, because hypoglycemia is a very, very can present as loss of consciousness, and you don't want to forget it, especially in a hospitalized patient who may have been inadvertently administered insulin, which I can tell you has occurred more times than I would like to talk about. And then focal weakness, because a sudden stroke needs urgent intervention of a different kind. So back to our patient. So you've looked at him. He's anxious, he's confused, his respiratory rate is climbing, his SAT is lower than was documented in the chart, his heart rate is much higher than his normal 70, his blood pressure is much lower than his normal 140/70, and he is febrile. So I'm going to give you a gift, which is the UBC Rapid Assessment non-trauma tool that we give to medical students, and it's in your handout, and it helps you. If you can't remember at the bedside, keep it on your smartphone or keep it laminated in your pocket. It just helps you with what goes under airway, what goes under breathing, what's assessed under circulation, what's assessed under disability, and then a reminder to expose and call your friends. And then it also, on the lower row, tells you what to do in each of these cases. So if a patient is obstructing, like, do a jaw thrust. If they're gurgling, do some suction. If there's any derangement in their respiratory status, apply oxygen. Just take the mask off the wall, crank it up, put it on the patient. You don't need to page an RT or call anyone else to do that. You can do that yourself. And then establish IV access if circulation is compromised. I can't tell you how many times I've gone to the ward to assess someone who is septic or complaining or in respiratory failure. And yes, they have an IV, but it's a 22 gauge in their hand or in their forearm. And as soon as you go to bolus fluid, it's going to blow. So don't waste time establishing the IV yourself. Ask on the ward, who is the best person for starting IVs? Get that person to the bedside. Get them to start a large bore IV. And then, under disability, ask somebody to do a quick blood glucose monitor. And if their consciousness is impaired and a glucose machine isn't nearby, give them some dextrose. Give them some naloxone. You're not going to hurt the patient. And then I'm going to tell you how to call your friends using the SBAR communication tool. So the chart review, again, vital signs and the trends in the level of consciousness. Read the nurse's notes. The nurse's notes are golden. They will tell you very well documented and unbiased what has gone on with the patient in the last 24 to 48 hours. And all the clues are in the nurse's notes. Here's an example. Post-op patient, abdominal surgery. Patient confused and restless. Patient pulls out NG tube. Couple hours later, patient vomits. Half an hour later, patient complaining of shortness of breath, can't breathe. O2 sats 89% on room air. RT called. That's very indicative that the patient has likely aspirated. So nurses' notes are golden. So the primary survey, is done in the first few minutes of the contact, and on completion, we're going to go on to the secondary survey. So in the secondary survey, once you've kind of stabilized the patient, you've got them, they're not obstructing their airway, they're on oxygen, they've got a good IV, their vital signs are now somewhat improved. You can go through the chart, look through the chronic history, chronic illness, any psychosocial issues. Very important to document medications started and stopped recently. Any allergies, super important. Family history. Under legal and ethical issues, I would put code status. Who is their temporary substitute decision maker? Is that person immediately available? And then a systems review. The secondary survey, you're also going to examine in more detail. So he was complaining of chest pain, dyspnea, and abdominal pain. So you're going to do the cardiac, respiratory, and genitourinary system for sure. You're going to do a screening, CNS and MSK exam, and endocrine and hematologic systems. And then E is in the secondary survey, and that's examine, expose. I saw a patient who I was consulted with in emergency, and I was told that their vital signs were stable, pulled off the bed sheet. She was mottled from head to toe, and she arrested very shortly thereafter. So look for mottling. It's the intensivist sign of impending doom. And then review, as we said through the chart, review the medical records, and that's where you start to formulate your specific diagnosis or differential diagnosis, and you start documenting name, date, time, who called you, what you were called about, what you found. Start writing it down. So here's our patient. So you've done a bit of a secondary survey. He is now, his respiratory rate is climbing. His blood pressure is still okay. He's satting 92% on nasal prongs. He does have bibasilar rails, evidence of accessory muscle use, and he's got abdominal tenderness and mottled legs. So what should you order? So, here's a whole array of things that you could order. I would stick, here's another pearl, the things you can order at the bedside. The last thing you want to be doing is sending this patient down to radiology because they don't like it when patients arrest in radiology, and it also makes you look really bad, and it's bad for the patient. So stick with things you can do at the bedside. You can do a blood count, you can do a metabolic panel, you can do a blood gas, either arterial or venous. Don't waste time on an arterial if you can get an easy venous blood gas. They're just as useful, honestly. And often the blood gas will give you a lactate as well as a lot of other information. Do a portable chest x-ray. Don't send them to radiology. Do a set of blood cultures if they're febrile. Would you do a CT scan? For sure, you want to send this person for CT scan. He's got abdominal and chest pain. He's had a recent surgery. You need to know what's going on, but don't send him out of the department right now. Don't send him off the ward right now. You need to make sure that he's stabilized and his trends are improving, or he's intubated and supported before he goes to CT. So the initial investigations are guided by the physical exam, the patient's presenting problem, and stay away from a wide spectrum of studies in favor of testing that's focused on preserving critical organ functions and things that can be done at the bedside. A patient with respiratory distress and the potential for hypoperfusion can be evaluated with an arterial or venous blood gas measurement, and measuring the lactate, which is often on those point of care tests, is very helpful in identifying anaerobic metabolism, of which sepsis is on the differential diagnosis. Metabolic acidosis is a very important indicator of critical illness, even if you don't know the cause of the acidosis, and its presence should raise concern that an important clinical problem is at hand. So I'm going to digress for a moment, and I'm going to give you another gift, which is the pyramid approach to dyspnea. So when you get called to see somebody who's short of breath, your framework is it's a respiratory problem, it's a cardiac problem, or other. The Problem is that other is a large bucket, and you can narrow down your differential diagnosis of other based on of arterial or venous blood gas. So the top of this pyramid, other, which is the blood and the acid base, you can get all that information from a point of care blood gas. You can find out, do they have a metabolic acidosis? Do they have a respiratory alkalosis or acidosis? Are they anemic? Is methemoglobin present? If they've had a recent medical procedure, please look for methemoglobin, because there's medications that are given that can induce methemoglobinemia. So that's super important. And then cardiac can be ruled in or ruled out with, the history, an ECG and a BNP and a chest x-ray that can all be done at the bedside. And then, of course, respiratory is the biggest bucket and the base of the pyramid for dyspnea. So again, a chest x-ray is super important. It tells you if there's a pneumothorax, a pleural effusion, if there's any airspace disease. If it's completely normal, that makes you worry about a pulmonary embolism as a cause for respiratory distress and hypoxemia. And then very important to look at the diaphragm. If it's an elevated hemidiaphragm, that's a clue to an intra-abdominal process going on, such as some kind of abdominal catastrophe or ascites. And then airways. So this is a little gift, the dyspnea pyramid. So back to our patient. So we've examined him and we can compare the current findings with his previous status. So here's his current findings. He responds to voice. His blood pressure has now dropped to 82/40. Heart rate is elevated at 120. His respiratory rate is now in the 30s. His temp is rising at 39.4. He is satting 92% on nasal cannula at 2 liters per minute. Now, I always say go big or go home. I would have put a mask on and just cranked it up. I mean, you can't do any harm with increasing his oxygen saturation. He's using his accessory muscles. His abdomen is now rigid and he has mottled legs. His white count is 21. BUN and creatinine are elevated, and he has blood gas evidence of a metabolic acidosis. So I think you can see that the trend is definitely worsening. And aren't you glad that you went back and you reassessed the patient? So you didn't go back and do other things and see other patients. You really focused on this guy and you reassessed him. So what now? The data set is growing. We still lack a diagnosis, but it's time to intervene. So what now? So several interventions are appropriate. You've got him on oxygen, you've got IV access, you're giving him circulatory support, you're determining his reserve, and you're assessing likely diagnostics and treatments. So very likely this guy might need vasopressors, vasoactive drugs. He's going to need invasive monitoring, and you really are going to need to get him to the best site for care. And you're going to need to call for advice and assistance. This is where your friends come in. And so again, on this UBC rapid assessment tool, there is the SBAR communication tool. And I'm going to just run through that with you now. So F is for friends. Remember to call your friends. Very often we get very focused on the patient and what we're doing for them at the bedside, and we start to get tunnel vision. And fear does that. It takes away our frontal cortex and our executive functioning, and we get very focused, narrow focus, tunnel vision. And so this is where this mnemonic F, or friends, will get you out of trouble. So you go, oh yeah, I need to get other help. So SBAR is a tool that was developed by the military when communications could go down at any moment, and it is meant to relay the most important and most pertinent information and a recommendation in a minute or less. And you can do a good SBAR in a minute or less. Please use this tool. I'm sure many of you have been at the other end of the phone getting a very disorganized story, and it's very hard to figure out what's going on and what you need to do. If only the person was giving you an SBAR, that would have been great. So what are we going to do in this case? So situation. Who am I? Where am I? What's the patient's identity? What's the problem? Hi, I'm Dr. Holmes. I'm calling about Derek Hamilton on surgery. He is acutely deteriorated overnight. Background, brief. Admitting diagnosis, pertinent medical history, and outline treatment to date. He was admitted with obstructing adenocarcinoma. He had a primary resection and anastomosis. He was post-op day 6 now. He's been slow to mobilize. Overnight, he complained of chest and abdominal pain. He vomited last night. This morning, he's disoriented and restless. He says he can't breathe. And he has a history of hypertension on ramipril, allergic to penicillin. So the assessment. Summarize your assessment. What do you think is going on? And this is where you're going to need to have a top 3 differential. I don't want you to have 1. I want you to have at least 3. So he's in respiratory distress. Just say it. He has signs of septic shock. Say it. He's febrile. He's got a white count. He's got mottled legs, evidence of hypoperfusion. That's septic shock. If you want to give the detail, if the person wants the detail, he's got grunting respirations. He's not conversant. He's tachypneic. His breathing is shallow and irregular. He's satting only 92 on room air. This was on nasal prongs. His blood pressure has dropped. His heart rate is up. His temp is 39. His skin is pale, mottled, and diaphoretic. His white count is elevated at 21, and his BUN and creatinine are up from previous. His abdomen is tender, in fact, rigid. And now you have to state what you think is going on. Just state, I hypothesize that he could have aspirated, he could have a PE, but I am most worried about intra-abdominal sepsis. And then plan. Here's what I need you to do. So don't beat around the bush. You need them to come to the bedside. Say it. Just say it. It's on you. It's on them if they don't come. It's on you if you don't ask. Here's what we would have done. What else would you like to do? So I need you to come and urgently assess the patient with me. He's now on oxygen. We've established large bore IV access. We've initiated septic workup. We've started broad spectrum antibiotics to cover for intra-abdominal sources and also hospital-acquired and aspiration pneumonia. I would like to transfer him to the ICU and continue the resuscitation there. That would include maybe intubation and vasopressor support before we send him for CT scan. So be upfront. Is there anything else you would like me to do? So that's a summary of a good SBAR. You can deliver that in a minute or less. First few times, take a blank piece of paper and write it out so that you don't stumble, forget, and by all means, don't add more information than you need to. So the key points of this module. Patient outcome is optimized by early identification of patients at risk of life-threatening illness. Critical illness has common manifestations on physical exam and focused laboratory assessment. Even without an initial diagnosis, the patient should be stabilized while further evaluation and treatment continue. The initial history surrounds the presenting problem. A detailed and more comprehensive history places this episode within the context of the patient's hospital course and their illness trajectory. And finally, subsequent steps are determined by the patient's response to the initial treatment. So here's our objectives, and I hope that you have learned something from this case, that you have learned to recognize the early signs and symptoms of critical illness. You can now apply the framework, which is A, B, C, D, E, F, to the initial assessment of the critical ill patient. The ABCDEF assessment also specifies how treatments and interventions should be delivered in relation to assessment. And bonus, I've given you the dyspnea pyramid, which is a great tool to narrow down your differential diagnosis of dyspnea based on the physiologic and laboratory parameters. And I've given you the SBAR urgent communication tool that you can use in future. If you have any questions, please do not hesitate to contact me, cheryl.holmes@ubc.ca. I would love to hear from you. Hope you enjoy the rest of your day and your simulation exercises.